And our aim is to bring together researchers around the world to try and build health economics capacity, advanced methods, try and generate and disseminate health economic evidence to support the evaluation and the integration of genomic medicine into healthcare systems. This is a list of all the SIG conveners. So I co-lead the SIG with Didi and with Ilias, and then we have additional conveners who focus on different activities and different priorities. We're always looking for more people to get involved, so please do drop us an email if this is of interest. And if you're an iHear member, you can join the SIG and get regular updates on our activities. Okay, so on to today. So the format for the webinar is slightly different to normal iHear webinars, perhaps. So we're going to start with a Q&A with Professor Payne for 15 minutes. We'll talk a little bit about her career, and then we'll move on to a talk from Catherine for about 30 minutes on the topic evaluating and valuing pharmacogenetic testing. And then for the remaining time, we'll open up for some questions. So without further ado, let me close down my slides and I will introduce Catherine properly. So let me stop sharing. Here we go. So so Catherine is a professor at the University of Manchester. She's based in the Manchester Centre for Health Economics, which she led until very recently. She's been working as an academic health economist for, I think, over 30 years now, I believe, and really conducting work over the full range of what is possible in health economics, applied and methodological work in a variety of clinical contexts. Always some of that work with a particular focus on precision medicine and genomics. Catherine's also a registered pharmacist. She's an NIHR senior investigator. She's a member of the UK National Screening Committee Research and Methodology Group, and previously she was a member of the NICE Technology Appraisal Committee as well. So she has a stellar CV and a huge amount of experience to share. Before we get to her presentation, we wanted to tap into that and ask a few questions about her career so far. And of course, this is of general interest to everybody, but in particular, it's incredibly useful for the early career researchers in the group to understand how others have progressed their careers in this field as they plot their next steps. So, Catherine, let's begin. We'll start off with an easy one. So, reflecting on your career so far, and is there one, or is there perhaps more than one important decision that you've made in your career so far that has really helped you to get to where you are today?
I think yes, there is one sort of defining moment, if you'd like to call it that. And for me, it would be back in 1993 when I made the decision to apply for a fellowship to complete an MSc in health economics at the University of York. Prior to that, I was a hospital pharmacist wearing my white coat on the wards, charging around, helping people with their medicines. So yeah, that would be my career defining moment, I think.
And presumably at that time you were exposed to quite a few people at York in terms of teaching faculty who have gone on to be sort of big names in the field, I guess.
Well, yes. I mean, my personal tutor was Carl Claxton. So yes, I shared many a moment with Carl. Carl actually went on to be my PhD supervisor for the first year of my PhD, but then Carl went on to greater things. He was a Harkness Fellow, and so I decided when Carl did that I would get another supervisor back at base because I thought he would be having too much fun with Milt Weinstein in the US to be my PhD supervisor. So, but yes, I some names that I was on my course with me. Let me think. So we've got Emma McIntosh, we've got Jane Wolstenholme, we've got Anne Spencer, Steve Morris. I'm going to forget people. So yes, we were the same cohort at York.
Fantastic. If you've forgotten someone, you can just say it's because I cut you off.
Yes. Thanks.
I mean, that's a pretty clear-cut, good decision in the world of health economics to do an MSc at York, I think. So the first question was asking you to reflect on your past good decisions, and I guess question two I have for you is really the opposite of that. So, if you look back at everything you've done in your career, is there anything that you would have done differently? with the
Well,
red
I actually, because you're very generous. You sent me these questions beforehand, so I had some time to think. Yeah, I could have written pages on this, so I had to keep it short. I think two things: recognize and be more confident in my own abilities, and most importantly, learn to say no more often with the guidance of a mentor. So I was very fortunate to be promoted to my chair as a personal chair in August 2010. I honestly at the time did not feel I deserved the role. And so as a result, I think I panicked and I said yes to everything that came my way, which was not on reflection the best strategy. I didn't have a mentor, and I really, I would, if if you don't take anything else, if you don't listen to what I say in a moment when I'm presenting, please take away that I think the importance of having a mentor. They have a really important role in academic careers. They can help you think about your destination, whether you want to stay in academia. You you have to take control yourself. Obviously, it still remains your own decision, but having a mentor to help guide you through that process, I think, is really important, and really being a sounding board.
Yeah, I think it's great advice, and it allows me to do a little shout out for the I Hear mentoring program, which I've lost track actually of when applications are accepted and where we are in that process. But it's a very good scheme, not just for early career researchers, but for mid-career researchers as well. And you get really good quality time with people who've got a lot of experience in the field. So I would echo that. And on the saying no to everything, I realised that too late as well.
I
And
still do it.
if anybody is just starting out, there will always be another opportunity. You're not saying no and then it never comes back again. So bear that in mind. Now, one of the things that you've spent a lot of time doing, and possibly this comes from not being able to say no to everything, is that you've committed a lot of your time to supporting organisations like the UK National Screening Committee and like the National Institute for Care and Health Excellence. So, I mean, that is really you're putting yourself at the coal face of decision making in health economics there. Is there anything in particular that you've taken that has been quite valuable from these experiences?
Yeah, I mean, to reflect on why I said yes to I still struggle because I used to be right next to the patient, literally right next to the patient. Um, and I still sometimes struggle with thinking, well, what's the point of what I'm doing? Um, and so though these roles have given me the opportunity to realize the point of what I'm doing. So I think that's and they also though remind me how much there is to learn about the different research methods that health economists. It's a continual like CPD. You're always coming across new things, having to learn new things so you can communicate those new methods to the decision makers effectively. You've got to understand it yourself so that you can critique and then communicate those methods. So they've given me both of those roles have given me that opportunity. And I think sort of going back as well about this patient facing role that I used to have as a pharmacist, albeit 31 years ago now, I still remember that. And in my early days as a health economist, I was quite disillusioned by research because I struggled to see what the point of what we were doing was. We didn't have NICE when I first started. I'm that old. So it was, how can we actually make a difference? So when NICE was formed, I thought, aha, that's how we can make a difference. And yeah, I think it's helping make these population level decisions in an informed way and being a communicator. I think that's what I take from those roles.
Yeah, I think if I would encourage anybody to take up opportunities where you've got to communicate what you're doing to people who don't do what you're doing, whatever the situation, it helps you to clarify the ideas in your mind as well. So, looking in particular at sort of the early career researcher cohort, and I can see some of them in the room today. Um, if you were starting out again today, what advice would you offer yourself as an early career researcher in 2025, if you wanted to, focus on precision medicine, health economics, genomics, build a career in that space? Is there anything particular you'd offer as advice?
Yeah, I'm gonna sound a bit like a broken record. I'll go back, and this isn't specific to genomics and precision medicine though, but sort of generally get a mentor. I mean, really, because and try and go outside your current circle, because it opens up your horizons. I feel now we've switched to a lot of Teams meetings like this. I mean, this is great because people can join easily, but it does close your circle down and closes down opportunities to make friends and really get out there, and so having a mentor from a different institution would open up another circle for you to interact with, and encourage you to go out and talk to people. So going back to the genomics and precision medicine, I've never really been in the position to only work in that area, and I think it's very rare that a health economist will manage to do that. You'll get pulled into other topics. So it's difficult for me to say something very specific about that. But it is obvious. I mean, the volume of people that are on this, when I first started, it was me and Sarah Wordsworth, working in this area. That was it. So now it's going to continue to grow. It's not going to get smaller. And so there's going to be many exciting opportunities for people. So yeah.
Thank you, Catherine. I'm going to ask you one more, and then we'll go into the presentation. And it's, I guess, thinking about the field itself. And maybe this is addressed at the ECRs as well. But if you could give them advice to, what is the one burning research question that would benefit from people devoting their time and efforts to answering it in health economics and genomics?
The one question.
You can have more than one if that's too tricky. Are we doing a good job of answering or filling the evidence gaps in this field?
No, I don't think we are. Okay, I really don't think we are. So let's get. So I think I've been working in this space for a long time now, and one of my early projects was around UGT 1A1 testing for irinotecan. That was one of the very earliest things that I got involved with. And NHS England still haven't decided what to do about that, and still asking for economic evidence on that, and we're sort of 25 years down the line. So I don't think we're doing that good a job, unfortunately. Now, I don't know. I think we're getting better about thinking about the appropriate methods, but it's that final getting it into policy, getting it into things actually changing. That's the tricky bit, because there isn't an obvious route, and it's very confusing how genetic tests are funded, and pharmacogenetics spans prescribing and genomic medicine. So it's very confusing about how you actually roll things out, and really understanding what sort of evidence the decision maker actually wants to think is really important. And we're very wed, aren't we, to doing model-based cost effectiveness analysis, but we don't actually know if that's what they want. Sorry, I don't know, that was not very positive, was it? I was trying to be all upbeat.
No, realistic is good. Interesting you should mention that, because I have an email in my inbox today that I haven't looked at yet, with NICE announcing a new medtech sort of consolidation of processes today into a new medtech route that probably has some implications for this space that we work in. So I'll take a close look at that soon with interest. Okay. Thank you very much, Catherine. That was super interesting. And we're going to go into your presentation now. So if you could share your slides. While you do that, I'll just remind everybody that we're going to have a bit of time at the end for you to ask questions. So please do save them up. You can ask them, you can unmute and ask them at the end, or you can put them in the chat and we can come back to them at the end as well.
Okay.
And they don't have to be just presentation related questions. If you want to go back to anything Catherine has said about the building a career in that space, that would also be an interesting avenue to explore. So without further ado, I'm going to hand over to you, Catherine. We've got half an hour, and I'll give you a nudge a couple of minutes from the end, perhaps.
Okay, cool. Thank you. So thank you so much for inviting me to present. I've worked, as I've alluded, I've worked in this space for a while now. My first project in pharmacogenetics started in October 2004, I think, writing the proposal of 2003. So what I'm going to do today is try and draw on just a few of my example projects in the time that I've got available. And I'd like to sort of use these to sort of illustrate some of the interesting opportunities that the topic of pharmacogenetics has given me as a research topic from an economics perspective. So sort of to crack on, I always sort of have a slide like this to start. So these are screenshots of adverts in journals for healthcare professionals. And the common thing here is you see people looking very happy when they're taking their medicines. So that it's all hunky-dory, and pharmaceutical companies would have us all believe that everyone is delighted with their medicines. But the reality is this, that quite often we're not very happy when we take our medicines, and they don't always work for us in the way that was intended. So why do medicines work differently for different people? So let's just think about the simple process that happens when we take a medicine. So it could be a tablet, an injection, or it could be a cream that you've applied. So you've taken the medicine. That medicine has a drug in it. That drug has to get into the body, so it has to be absorbed into the blood. So that's absorption. It then has to move around the body, so it's distributed around the body. And the body does something to it. The drug is changed in the body in some way, because then the body has to actually get the drug out of the body, so it has to be excreted. And the things that make medicines work differently are down the left-hand side. So it could be how old you are, other diseases, whether your kidneys or your liver work, whether you've taken other medicines, or whether food can interact with medicines as well. So the thing we're interested in is the genetic makeup of individuals, so pharmacogenetics. And quite often the thing that gets influence from our individual genetic makeup is how that medicine and drug is metabolized in the body. Now, not always, but this is generally what happens in terms of some variation in how the body reacts to a drug. So there are proteins in our body that form enzymes that are metabolic enzymes. So they metabolize the drug. So that's what we're really talking about today, some genetic variation in some of these enzymes in our body that mean we respond to that drug in a slightly different way. So there's loads of definitions of what pharmacogenetics or pharmacogenomics is or might be. I try not to get caught up in whether it's genetics or genomics. But really, we're looking at here the study of inherited genetic variations that mean individuals will respond differently to medicines. And that genetic information should be useful so that we can target people to receive only medicines that are safe and effective. But we're talking at the patient population level. So we're talking about subgroups within the population that are maybe they should have this medicine or they should not have this medicine. And we're obviously thinking from a health economics point of view that we're going to derive on balance some positive benefit. Now that might be health improvement, or it might be something wider than that. But we generally focus on health improvement within a lot of the modelling that we do. So this is kind of a key sort of take-home sort of slide, really, that pharmacogenetics is giving you additional information, but it's not often perfect information, and it's there to inform prescribing decisions. That's what it's for. It's not going to predict all side effects that might come from a particular medicine. It will not perfectly predict who is a responder, because there's loads of things that might influence whether or not you respond to a medicine. What it might do, though, is reduce the number of trial and error medicines that you as a person end up trying out before you find the correct one for you. And it will also influence the cost of the actual provision of prescribing and taking of medicines. So there's a cost implication there. So that's why health economists are important in this area. So as I've already mentioned, pharmacogenetics has really been around a long time. I don't know whether some of you realize just how long. So it was Pythagoras who first spoke about pharmacogenetics, who observed that some people who are on a Mediterranean diet sometimes drop dead from eating fava beans. And this actually turned out to be related to G6PD deficiency. And obviously Pythagoras didn't know that, but the Pythagoreans all decided they might avoid eating fava beans for that reason, because there's a risk they might not be a good outcome. So it's been around for a long time. And we've already alluded to this in the sort of the pre-chat, that things are kind of progressing, but not progressing that fast. So when it all started, it was very much looking at a single gene medicine kind of interaction with a laboratory developed test. And I've got the example there that I'm going to draw on in some of my later slides, looking at TPMT testing for azathioprine. We then start to see sort of point of care pharmacogenetic tests. So we've got, again, one of the examples I've got is looking at CYP2C19 testing for clopidogrel. And you've got looking at variants there for gentamicin, which is an aminoglycoside antibiotic, and some babies are at risk of going deaf if they are exposed to that particular antibiotic. So these are point of care tests. We're also now starting to see panel tests, either within a disease. So there's some big work being done in Canada looking at panel testing for different antidepressants, or across diseases. And I've got, I'll mention a study that I'm involved with that's sort of ongoing at the moment, looking at introducing a pharmacogenetic panel test into primary care. And the future really is thinking about more widely how we integrate pharmacogenetic testing with the associated required IT infrastructure, so that it's embedded into healthcare systems. So not piecemeal, but across general practice and across hospitals. And that future might be close, or it might be a long way. I don't have a sense yet about how near we are to that. So this, I'm going to just sort of go through a few examples now. This was one of my first projects. I worked with colleagues at the University of Liverpool, and Roche at that time had launched this product called the Roche AmpliChip CYP450 test, which had a number of different applications, because it included CYP2C19 and CYP2D6 as genetic variants, which have a lot of applications across numerous medicines. And NIHR, which is a major funding body in the UK, called on Liverpool to do a health technology assessment report on the Roche AmpliChip in a number of different applications. Now, this one was focused on typical and atypical antipsychotics. And so they looked at how you might use it to test for polymorphisms in adults with schizophrenia. And showed that from a clinical point of view, there is a possibility of an improvement in outcomes. But when we started to attempt to do the economics, it really was not possible to do that. We really struggled in linking data from clinical outcomes to gains in health. And most importantly, really struggled to see what the current prescribing pathways were for people who were taking typical and atypical antipsychotics. And as I've mentioned already, that is important, because you need to know the change that can be introduced by using this pharmacogenetic test. You really want to be reducing the number of switches that people need, so they get on the right medicine straight away. So to look at the value of that, you need to understand what the current prescribing patterns and pathways are. And we that was just not possible. So this was a kind of couldn't really do very much in terms of the economics for this particular example. So the next study was looking at azathioprine and TPMT testing. We call this study Target. There's a lot of studies called Target, so we're one of many. So I worked with a colleague who's a geneticist called Bill Newman on this, and Bill and I developed this proposal which went to the Department of Health to conduct a randomized controlled trial. So it's a prospective RCT. And what we wanted to focus on was understanding the clinical and cost effectiveness of using TPMT testing for this medicine called azathioprine. Azathioprine is an immunosuppressive. It's used in a number of inflammatory diseases, but neutropenia, which is low white blood cells, can occur in between 5 and 15% of patients. Why is neutropenia important? It exposes you to infection, and that infection can kill you in some instances. So what clinicians do in the absence of testing is be really sort of softly cautious in introducing azathioprine, and do that in a stepwise way. So you introduce a very low dose and then gradually creep the dose up to the maintenance dose or the active dose, and monitor people's blood alongside that. So quite a costly and slow process to get people on the active dose for that medicine. So the TPMT test can be sort of phenotypic, so it can measure the actual active enzyme level, or DNA based. It's around £30 a test at the time, and took at the time around 5 to 10 days, which was fine because these are inflammatory diseases. You're not talking about needing to do things very quickly in terms of changing medicines. So really what you would get from the result from this test is hopefully reduce the probability of this profound neutropenia, and individuals would be returned into one of three groups: sort of normal activity, so give them azathioprine, everything's fine; intermediate, give them azathioprine but be a bit gentle with the dose; or they've got no activity in this enzyme, don't give them azathioprine because you will kill them if that happens. So those were our three groups that we were trying to find, and we set up we wanted to set up this trial, and in a project that ran alongside this, which was funded by the European Commission, we informed the need for this trial by doing a systematic review. So back then, this is in 2008, I believe, we found 6 economic evaluations of TPMT testing, and they all said TPMT testing should be done. So we thought, oh blimey, we're not going to have we're not really in sort of equipoise for this trial then if everyone says we should be testing. But when you sort of got under the bonnet of some of these economic evaluations, they were basically guessing a lot of the time for some of the key parameters. So we didn't really know what the prevalence of profound neutropenia was with azathioprine. We didn't really understand how testing was changing prescribing and subsequent care pathways. We didn't really know the number of cases of neutropenia reverted and the link of that on mortality and quality of life. So a lot of these were informed by guesses or expert opinion. So while the models were saying, yeah, it's cost effective, the evidence supporting those models were not that strong. So we went ahead and put an awful lot of effort into this trial. Our initial plan was to recruit 1,000 people. As you can see, we fell quite a bit short of that, in that we got 167 in the TPMT arm and 166 in the current practice. That was because as we started to roll out our trial, major clinical groups started releasing clinical guidelines to say you should be testing for TPMT, which ruined our clinical equipoise. And so we were scuppered, but we ploughed on regardless, because this is one of the very few examples of a trial in pharmacogenetics, and we did have rheumatologists who were very keen to still allow their patients to take part. So the majority of patients were rheumatology patients. We collected resource use data alongside the trial and EQ5D data. and came up with this result. So you can see, if we focus on the 4-month time horizon, we did show that TPMT testing was cheaper, on average around £420, but we also lost a bit of health there. So we've got all our scatter points down in the southwest quadrant, which is suggesting that TPMT testing is saving you money but losing health. So we pondered that a bit and thought, well, why is this happening? So we went back to the trial data and had a look at what was happening in terms of the doses of azathioprine that were prescribed in the active arm, so the TPMT arm, and the control arm, and there was no difference. So what that told us was the clinicians were taking part, but they were going, oh, that's interesting test result, but I'm still going to carry on and do what I was doing beforehand. So it was then down to basically luck whether you ended up with a positive or negative gain in QALYs. It was nothing to do with the intervention, and clinicians really weren't following the test results. And this really, I think, was a defining moment for me, when I actually then subsequently went on to produce other economic models, thinking about the importance of thinking, well, what happens if we don't get perfect uptake of the test result? So it's that imperfect test uptake which becomes really important. So alongside this, we also did a discrete choice experiment as part of this trial. I worked with Emily Farger on this, and so in this we wanted to understand what the patients and the healthcare professionals thought about this idea of pharmacogenetic testing, and we built the discrete choice experiment around these 5 attributes. We had 159 patients and 138 healthcare professionals who completed the DCE, and you can see that it kind of worked, because there was a common sense answer in that they both were willing to wait some time. We didn't have cost in there because we're in the UK, but we used time to a test result as our value attribute, if you like. So they were willing to wait a bit of time to get an improvement in test accuracy, which was great. The interesting thing we found that the patients were really more focused on wanting information about what the test was about, whereas healthcare professionals were almost exclusively focused on predictive accuracy and turnaround time. So that's an interesting finding when you think about trying to design a service, that you really got to think about information for the patients, and try and convince the healthcare professionals that that's important when they're all focused on test accuracy and turnaround. So we had no role in this. So we did those 2 studies, and then eventually azathioprine and TPMT testing got into the British National Formulary. So you should test for this. Nothing to do with any of the research we did. It just happened anyway. So feels like, well, that was a waste of time. But I learned, I think, more with that trial and that DCE. That was a real sort of defining career moment for me in terms of thinking about how I would design studies going forward. And the real take home was, don't try and do a trial around pharmacogenetic testing, because you'll end up with a lot of grey hairs and very few patients. So my next example is a model-based study, and we worked with a company called GeneDrive, who have developed a point-of-care test kit looking at CYP2C19, which is relevant to a medicine called clopidogrel. That can be used in a range of different conditions, but our focus was ischemic stroke for this particular model-based study. Now, clopidogrel is a prodrug, so that means, going back to my little schematic I showed you at the beginning, I'd have to introduce another little box, because to turn into an active medicine, clopidogrel needs an enzyme. So that CYP2C19 turns clopidogrel, which is a prodrug, into an active drug, the drug that does the work. So that means that you need that to actually get enough drug in the body. So GeneDrive have developed this test. They were looking at charging around £60 per test, and we wanted to do an early economic analysis to see if, on the face of it, this would be a good test for GeneDrive to actually roll out into clinical practice. So what this test actually does is potentially influences the probability of having a subsequent stroke. Because obviously, if the prodrug doesn't turn into the active drug, well, clopidogrel is not going to work for you. The other thing we need you to be cognizant of is that not everyone tolerates clopidogrel. That's got nothing to do with genetics. That's just tolerability. So with that in mind, we designed an early economic analysis built around a decision tree. Now, I say we, it was myself and Stuart Wright that worked together on this. So Stuart sat down with the clinicians and the gene drive people and tried to build as simple as model as possible. We wanted to do this quick. We wanted to do this early so it could inform subsequent studies. So we built this decision tree looking at clopidogrel versus alternative medicines that would be used for the management of stroke. So you've got dipyridamole and aspirin there that were sort of a combination of therapies. And that tree then moved into the Markov model, which would capture the stroke component of this decision problem. So what we found here is we identified a possible eligible patient population in England of around 60,000 patients with a starting age of 67 years. Again, you can see it's cost saving. So it was looking at the tests compared with current practice, it was cheaper, but we did see some modest QALY gains here. And if you start looking at total net monetary benefit, it was looking very positive using a threshold of £20,000 per QALY. So you're getting a sizable total net monetary benefit there. If you looked at the unit cost of the test, it could go up to quite a substantial amount. They could charge nearly up to £1,400 and it would still have a positive net monetary benefit. And on the tolerability side, that could fall as low as 4%. So it was an incredibly robust result, really. This same topic was then picked up by NICE. We did not do this modelling, so we're not an evidence review group for NICE at the University of Manchester. So it was the University of Bristol that picked this up. They did get in touch with us, and they took Stuart's model and had a look under the hood and moved this on to the next step, really. So rather than it being an early analysis, it became a definitive model. And this resulted in this diagnostics guidance. So this I felt we did have an impact. We did inform the model structure. It doesn't look the same as the model that we developed, but they drew very heavily on what we had done. So this was a positive thing for me. I'm still working with Gene Drive. We're now looking at this genetic variant for gentamicin. This study has just been funded as part of, I think there's about 7 or 8 studies been funded by a joint investment by NIHR and the Office of Life Sciences in the UK. And so again, I'm working with Bill and colleagues. They're called the study PALO. So this will be, they are looking at rolling this out in a number of different neonatal units, and we will be building a model-based analysis around this gentamicin. And really important here, thinking about uptake as part of that model, because that is really what's going to drive this in terms of cost effectiveness. The other thing I'm currently working on at the moment is with Bill. Bill has been sort of a constant for me. He's the pharmacogenetic guru on this. So we are part of a network of excellence that Bill is leading, and we are looking at a study called Progress, which is trying to roll out pharmacogenetic testing as a panel test in primary care. And so they have this assay which has the capability, I think, of about 142 different medicine gene pairs. But they're doing this in a stepwise fashion. So at the moment, looking at 4 case studies. So you've got statins, SSRIs, proton pump inhibitors, and the analgesic codeine, rolling those out across different general practices. and using the CPIC consortium recommendations to tell clinicians what to do if they find any genetic variation in the individuals that are recruited to this study. So our current challenge is, how do we produce a model-based cost-effectiveness analysis of a panel test? Because that is a multi-headed beast, and your model could incredibly get very complicated very quickly. So that is our current challenge. Alongside that, I've been involved with some more preference work, and John McDermott is the PhD student who got a fellowship from the National Institute for Health Research in the UK, and his PhD had a clinical aspect to it, but he also included a discrete choice experiment, or 2 discrete choice experiments within his PhD. And the first thing he did was look at what the public think about this. And he built this around 2 case studies. So depression or low mood, and pain. So looking at codeine as, and you can see he got a sizable study sample there to complete this DCE, which was built around the 4 attributes you see there. So the type of test, the data availability to patient, how the future data availability to healthcare professionals in the system, and the turnaround time. So he produced a number of different analyses as part of this, but what I just wanted to present to you here is he calculated the predicted uptake using the results of the DCE, using a scenario-based type approach. So he defined a base case service that you can see there. So it's a blood test. Data were not available to the patient. No data were available to healthcare professionals, and it took 20 days to get the test result. And using the results of the DCE, predicted an uptake of just over 50%. So not good, really. Then he optimized that service and said, okay, cheek swab, because that's what the patients wanted. Yes, you got the patients got access to the data. We aligned with the preferences for regional data being made to healthcare professionals, and improved the turnaround time to 10 days. And then you could get an uptake of around 99%. So this really shows how modifying this complex intervention, which is a pharmacogenetic test, you could potentially improve the uptake in clinical practice. And he repeated the same concept, but used a completely different design of DCE in a sample of general practitioners and pharmacists, again around low mood and pain, but used different attributes that were more relevant to the healthcare professionals. So you got the type of data reported, the return of results, the chance of the medicine being effective, the chance of a side effect, and your turnaround time, which is a constant. So when we had his base case, which you can see there, was focus data, results came back by post, chance of effectiveness was 50%, ADR was 20%, and turnaround time of 20 days, sorry. You got uptake of 33% for GPs and 55% for pharmacists. If you optimize that, so you had very focused data, so narrow data rather than focused data, used an electronic health record, so all the data went straight onto the patient's EHR. Effectiveness was now 53%, and a chance of an ADR was 5%, and turnaround time was quicker at 10 days. You could increase uptake using the preferences we saw to 93 and 96% respectively. So again, this idea that you can use a DCE to really think about refining your model of service delivery.
So 2 minutes, Catherine. And
I'm on my last slide.
Brilliant.
Oof. Hey, that was random. So what do I want to end with? It's, if anyone's working in this area, it's great. I mean, it's a high profile, policy relevant topic. It's got many opportunities for economic evidence to inform clinical practice, and we've got a big toolkit, if you like, in terms of methods that we can offer. pharmacogenetic testing is going to continue to evolve, though. It's a complex intervention and we should treat it as such. It's not just a simple test. So it's thinking about your methods of evaluation needing to continue to evolve and recognize the complexity of the test itself as being embedded within a model of service delivery. Now, trial-based cost effectiveness analysis is useful, but I really think it's models that are going to be our friend here. And these models need to take account of not only the test accuracy, but also uptake. And it's the uptake that I think is vital. Pharmacogenetic testing will always look cost effective if you assume perfect uptake, but you ain't going to get perfect uptake in practice. And so that is the crucial thing, really. And DCE's a really useful role in looking at informing models of service delivery, and sort of it might for me it's really introduced some challenges for how you conduct these model-based cost effectiveness analysis, quite often without the data that you might need. So it's about doing this in an iterative way and doing as well as you can with the data you have, but continually trying to improve your models. And I've not thanked enough people as I've gone through, but I've worked with an awful lot of people on these projects, and I couldn't have done it without them. And you can tell Bill Newman has been a constant, John McDermott's a constant, and Stuart Wright and others. So thank you. Should I stop sharing?
Yes, please, Catherine. Yes, brilliant. Thank you very much. That was fascinating. I mean, I know some of those studies. I've read some of those papers, but I still learnt some things today that I didn't know. And also such a rich data or group of data sets you've been able to build over the years in this space. So fantastic. Thank you very much. We're going to open the floor to questions. We've got about 10 minutes. So I'll let you have a minute's thinking time. As I do so, you can unmute, put your hand up and then unmute and ask your question out loud. Or if you want to pop it in the chat because you don't want to appear on the recording, that's also fine, and I can read your question out for you. But hopefully we'll get some questions. Otherwise, it's me asking Catherine questions. Sally, brilliant. Let's start off with your question.
Thanks, James, and thank you, Catherine. It was a really interesting presentation. I have so my question is about working with industry. And as someone who's quite new still to academia, it seems to me that some people may have a perception that working with industry, there's some negative connotations around that within academia, particularly when there's funding involved. And looking at some of the project examples that you presented, with Gene Drive and such, really fascinating projects that maybe would not have been possible without that collaboration. And so I just wondered if you have any, thoughts on those perceptions and how you've, maybe worked to combat those while working on these projects.
Yeah, that's a really good question. So, as I've said a lot of times, I'm a pharmacist, and so we have an inbuilt distrust of industry, have to be honest, and that is because when you're baby pharmacists, you used to have drug reps come in and try and sell you their drugs, give you M&S sandwiches and nice big cakes and try and persuade you. Can't do that anymore. But that really that was important. That was a defining career moment, if you like. So I am wary of working with industry, but wary in a good way. So I go in thinking, right, we're in this together, so we've got to work. It's pointless not working with industry, I'd say that. But from the beginning, you've got to both be very clear what your working relationship is, what you're going to do in terms of how you present the data, who's got control of what, and just having a contract, be it formal or informal, but an open chat at the beginning about what they want and what you can offer them, and just being open with that. It's different if they are paying you, and I've not been in that situation. So we've gone into we've applied for public funding and worked together. I've not yet worked with a company where the company has actually paid me. That's a different arrangement. So I don't know whether I'd feel slightly different in that sort of style, where so with the Gene Drive, we're very much in it together. We applied for external funding, and so it's all fine, I think.
Thank you. That's really useful. I think that's a really important distinction.
Yeah. I think there was
Thanks.
a question in the chat, was there?
There is. I mean, Dante, I guess, is reflecting on the difficulties of doing a model-based economic evaluation when you've got a panel test and you've got a load of different things that you could include on the panel. What's the best way to do this? Is this to sort of focus on the most likely to be cost-effective genes in the panel, or is there a different approach?
Well, yeah, you don't know, do you? That's the problem. So you so what are we doing? We're starting with the things that we think are the most challenging, which maybe is a stupid idea. So we are picking two and trying to model this for two examples. So I didn't have much time to do that. So the panel test is interesting because it's not only a panel test, it's a panel test and they're storing the data for future reuse. So it's so we're reacting to the initial medicine. So the patient presents in primary care and they're going to start an SSRI or a statin. GP orders the test result comes back for that particular prescribing decision, but then those data get stored, and obviously then they will be relevant for other medicines that the patient starts in their future life. That's the bit that makes it tricky, that reuse of the data. So we've picked two drug gene pairs, and then we're going to include reuse of the data once. Beyond that, our model's going to look like, well, we'd never finish it. So that is our strategy. And then you could go back and think, right, we're doing it in a modular way as well. So we're kind of building a tree and a Markov model. So then, and using R. So in theory, you could then go in and add in more modules as you get cleverer. But I'm not sure we'll ever get to that point. We'll probably stop at 2.
It is tricky. It is tricky. Not just as you get cleverer, but also as more data becomes available.
Well, there are no data, so that's
yeah.
the other. Yeah.
There are no more hands up, so I'll ask a question for now. There's been sort of you'll know this as well as I do. There's been a sort of a common refrain in health economics that standard HTA approaches don't work as well, or may not work as well in the context of genetic or genomic interventions. But I think in pharmacogenetics or pharmacogenomics, I've always been a bit skeptical that that's the case. So what's your position on that in the context of pharmacogenetics?
Well, so I alluded as part of the DCE result, the first DCE, that patients value more information. So we're not as part of that's what they get out of pharmacogenetic. They like the fact that they're getting more information. So we're ignoring that benefit in your standard H. So that's the only thing I'd say. So I agree with you. If we want to focus on health gain, and you know, James, I've done quite a bit of work around looking at the value of getting a genetic diagnosis and how you actually capture the benefits from that. So you ignore all that and just look at the health gain from getting on the right medicine, then yeah, it's easy. But I think you are perhaps not capturing the full potential value of pharmacogenetic testing in that way.
Yeah, I think we might be in a similar place in response to that question. I guess following up on that, I suppose, you've talked to patients, a lot of members of the general public, I guess, as well, through DCEs and other bits of work. And I guess you've probably got a sense of the acceptability of pharmacogenetic informed prescribing as well, because it's not just having the information, it's using the information as well. So do you have a sense that people are generally accepting of, getting a lower dose if they're a high metabolizer? I think that's the right way around, and so on and so forth. I know in other contexts, people have been there's been some pushback about using genetic information to inform clinical decision making for ages. That people said, oh, you couldn't tell people they were going to get less intensive breast cancer screening. People wouldn't accept that. But in the context of pharmacogenetics, is that the case, do you think?
It's all about how you communicate with people in a way that's meaningful, and I think there's going to be a need. This is why it's a complex intervention, because there has to be a change in terms of how medicines are prescribed in general practice. It can't simply be your GP sits down and says, right, I'm going to start you on a drug and presses a button. There has to be some discussion and understanding about there's the possibility of selecting if within a class and trying to pick the right one within that class for you, and this particular test can help us with that. So you have to open up that dialogue, and the pharmacists have to be involved as well. And it's relatively easy in a hospital environment for that to happen, because you're all kind of in the same building and you're rubbing shoulders with each other. But when it's in general practice and you've got, in the UK, you've got your pharmacist on the high street, that interaction is not as easy. And so thinking about how that happens as well is really important.
Absolutely. Thank you. We have maybe a time for one more quick question, if anybody has a burning question for Catherine.
Done silence, or they've bored them to death.
The former, of course, the former. Okay, let me wrap up. I'm just going to share my screen one more time. There we go. Okay, so just well, I mean, first and foremost, thank you, Catherine. That was fascinating to hear about all the work over the years. There's so much scope, as you said, to do interesting work in this space and to apply sort of cutting edge methods, and particularly on the modelling side. So I would encourage anybody thinking of what next to do in precision medicine and genomics. Pharmacogenetics is a good space to start working in. Thank you for your questions. Please do join the special interest group if you're not already a member. You can follow us on our socials. I've mentioned Twitter on the slide. We're also on LinkedIn, and you can continue the conversation from today on either of those forums as well. We're currently finalising plans for the next webinar. I think it may well be ECR focused, but we'll publicise that in the coming weeks. So keep an eye on emails if you're a SIG member, or on our socials, either way. Okay, that's it for today. Thank you very much, Catherine, and thank you to everybody who's participated, and we'll see you all again soon. Bye-bye.
Thank you.